Hi, and welcome. My name is Peter. I'm an emergency physician from Denmark, doing my residency in Stockholm. And today I wanted to talk with you about ECG interpretation for the emergency physician. This is a lecture I've wanted to be doing for a long time, and ECGs, I think all of us in emergency medicine think is one of the most important things, bedside tests that we can do. It gives a lot of information. There's lots of diagnoses that can be made, but it's also really, really hard. And I don't know about you, but I certainly have a imposter syndrome about ECGs because I think all my colleagues are much better at it than I am. I recently did a course as an instructor in Belgium, and I've done several of these emergency medicine core competences courses as instructor, where I've shown and educated people in ECGs. And I wanted to share with you today some of my pearls about ECGs. I'm sure lots of you are much better at this than I am, and I encourage you guys to look up the references that I will be showing on the next slide, because I think that all of us can gain something from this. All right, without further ado, let's get into the lecture. I made the lecture in three parts this time. Part 0, where I go through some of the basics of ECG, and I also go through the references that I would encourage you all to look up because they're great, and I'll be using some of the pictures from those references. And in part 1, where I'll be going through the systematic way, one systematic approach to the ECG, and then the part 2 is where I will be sharing with you what I call the Syndromatic approach to ECGs. I will go through what that means, the systematic and the syndromatic approach. But if you've seen my other lectures and know about what I think about syndromes and diagnoses and so on, you probably can guess already that it's something about system 1 and system 2. All right. So here are the ECG references that I've been using. For the general purposes, I think one of the best encyclopedias in the world of FOMED and emergency medicine blocking is Life in the Fast Lane. Life in the Fast Lane, if you want to know something specific, like why is this, how long should the PR interval be, how does a hypertrophic cardiomyopathy look, then I think that block is probably the best. So you Google whatever specific finding you want, and then you can find that. If you want more case-based learning, either randomly or in theme, then like randomly you have the ECG library cases from Life in the Fast Lane. These are really good. Personally, I prefer the EM cases, ECG blocks, which I think are amazing. They are a bit biased towards occluding myocardial infarction ECGs, but they do it really, really well at learning or teaching us about the nuances through cases there. They have a great build-up, I think, because they do like maybe 5 or 10 cases where you don't get the answer at first. Then they have a middle section where they teach you the theory behind this specific topic, like T wave inversions, and then they afterwards give you the answer to the cases, and then they come with a conclusion. I love this build-up, and I use that a lot. Okay. Then if you want a Bible in this, I have the first version of this book, which is not by Mattu, but the second version is by Mattu, called Electrocardiography in Emergency and Acute and Critical Care. It's a book that is mainly syndromatically built. So if you want to build your syndrome management of ECGs, then you can check out this book. That is also what I will be going through in the part 2 of this lecture. ECG Stampede is a app, and the creator of the app also has like a algorithm block, and yes, it's quite cool and it's quite unique. And the ECG Stampede is like you're standing as a triage doctor. What kind of ECGs you're going to see, like a couple of ECGs, and then you have to decide, oh, do I go to the resource bay? Do I go to the waiting room, or do I set this patient as the next patient? And I don't always agree with the reasoning and the answers, but I think the concept is really good. But it's a bit American. But I think, well, I may be 80% in agreement with what they say. So it's a good app to check out. ECG Waves is a non-emergency medicine page, which is also like an encyclopedia, but it's partly pay site. So that's why I don't use it that much, but for specific things that are on the free side, it's good. For the more specific syndromes that we'll be going through in the part 2, then you can check out these FOMED links, and also these. There are much more. These are just some of the more specific ones, and some of my favorite ones on the specific topics. Also, I have made a video on the specific syndrome of ischemic or chest pain in the patient presenting with chest pain, and specifically talking about the OMI, the new paradigm that I think should be using, and I'll get into that just a little bit in this lecture as well. But for the more deeper dive on that, I encourage you to check out my other video. Okay, so a bit of basics before we head into the systematic approach to ECGs. So I can't go a video without talking about probabilistic thinking and Bayesian thinking. So we often think like this, that chest pain, if you have a patient with chest pain and you do the ECG, if the ECG is negative, then you have no ACS, and if it's positive, then you have ACS. And of course, according to a probabilistic worldview, then that is not correct. There certainly are chest pain patients that may have a normal ECG, but still can have a ACS, even an OMI. Especially if you take the ECG maybe 30 minutes later. So it's all about probabilistic thinking and weighing in different data points on the ECG. So the ECGs are a tool, not a diagnostic machine that dichotomizes the patients. That doesn't. In certain cases, there might be ECGs with chest pain or with other presentations, so atypical presentations, especially in women diabetics and so on. Women diabetics and elderly may have atypical presentations, dyspnea, fatigue, sleep problems, and so on. And especially with younger women, we should probably work up more than we are doing, as there's an over mortality. There's a great SMAC lecture about that. Mattu has done great lectures about the biased literature in the ACS. So not only chest pain. So that's just, these things are probabilistic, and we have to weigh in different things. That's why I'm doing a lecture on this, on ECG interpretation, because if it was easy and could be algorithmized easily, well, then we didn't have to know all this stuff. All right. One version of this is the STEMI, non-STEMI paradigm, right? So we think a patient with chest pain have an ECG, and either there's a non-STEMI or STEMI according to the STEMI criteria, which would be more than 1 millimeter of ST elevation, right, in neighboring leads. And as absurd as the last slide was, then apparently this is still what we think is the right paradigm to go through with the OMI and with our STEMI non-STEMI paradigm. And we should not think of this as a diagnostic entity. We should think of it as a highly, as a quite specific and with a high likelihood ratio of there being an OMI. But things that do not live up to the STEMI criteria, the one we call non-STEMI but OMI plus, they have at least as high a troponin leak, according to the Smith's studies on this. Dr. Smith and others have made these studies that I've gone through in the other lectures, and it's really important that we see that 25% of these that we dichotomize as non-STEMIs should be having PCIs right away. All right. We should probably, if we want to use this kind of setup, we should talk as if it's in likelihood ratio in likelihoods. So if there's ECG and there's no signs of OMI, then it's a lower likelihood of an OMI. Doesn't mean that the patient with the constant chest pain doesn't have an OMI, right? Our ECG is not a diagnostic machine. It's a tool that we use. We are the diagnostic machine that we have to interpret all of the things. So in our toolbox of diagnostic tests, the ECG is a really important test, but we should use the other stuff as well: blood samples, exam, POCUS, and history. And don't look blindly on the troponin. If there's obviously an ECG finding of an OMI and you have the right history, then don't wait for the troponin. Oftentimes they're not positive anyway, and they're not just slightly positive in a lot of the very serious OMIs. So, all right. When we look at our ECGs, as I've been alluding to, we have two ways of looking at it. Either we can look at it from a more systematic approach, like a bottom up, where we do a thorough analysis of the ECG every time. That is not how we usually look at ECGs, at least not when we have been doing this for a while, because then we have some kind of pattern recognition. And we more likely tend to look at it at a more syndromatic kind of way. So if you have a chest pain patient, you will look more in the ST and T segments and maybe the OMI patterns that you know. And you will not look that closely if it's a syncope patient, but you'll look for other things in the syncope or transient loss of consciousness patient, right? So there's different ways we look at our pretest probability of disease and syndromes determines how we look at the ECG, just as with any other test. But if we don't know what we're looking for, we do need to fall back on some kind of systematics, and that's why I'll go through the systematic approach to an ECG in this lecture, in the part 1 of this lecture. So there's different ways of going through systematically, and I've just chosen one that we use in the EMCC course, which is called OPQRS T+, and it's good because it fits with our history, and which is also a OPQRS T+ mnemonic. But there are others, and for instance, EM cases use a Hart's mnemonic, and then you can look that up, for instance, in the ECG cases episode 5. For the syndromes, there's plenty of syndromes. As I mentioned, the Mattu book that I referenced in the beginning here has only syndromes, and there's sub-syndromes of the syndromes and so on and so forth. So I just picked out a couple that I think are really important, and I think is high yield for all of us to know. And I do believe between all of this, I think that's 90, maybe 95% of what we actually need to know as an emergency physician in ECGs. And please correct me if I'm wrong. Please comment if you have any other suggestions. As always, I'd like to just mention a bit about System 1 and System 2. And one of the things here that's barely readable, sorry, is we can make something that is that was analytical system 2, we can make that system 1 by deliberate practice, right? And so if we practice a lot, then all of this, like, this becomes more second nature to us. So we don't have to painstakingly go through all the steps in the same way as we were when we were novices, because then it's system 1. But we should still there's still a risk that we may miss stuff, because when we go into system 1 mode, then there's a risk of biases. It's faster and it is much better, but we have to, like, this magic skill to know when we should go to system 2 and how to do that. Well, I talked about there's what you would call forcing strategies. Maybe you have a checklist or a stopping rule. Maybe you have a feeling or mindfulness, that kind of mindfulness feeling that tells you, or awareness that tells you, oh, this patient is a bit different. I don't know how, but I need to go through it thoroughly. Some would argue that if you don't know the pattern, then it doesn't matter to go through systematically. There's a cognitive psychologist, Norman, who says either you know it or you don't. But I believe certain ECGs probably need a better second look, especially if the patient is not turning the way that you suspected. There's always the problem with there is an inappropriate way to go here from system 2 to system 1. If you're really tired, or you don't really know the OPQRS, then you might skip some of them, skip some of the elements of this, and inappropriately so go to system 1 and just, oh, it's probably not important. And many times some of them are less important than others, the elements of this. But you need to kind of be aware when you which ones you can skip or which one you can't. You can't skip ST elevations, for instance, in the ischemic patients. But all right, so that would be an inappropriate way to go down here. And you can also go from system 1 to system 2. We talked about, well, if I think this ECG might be a bit, there's something wrong, I don't know what, but there is, and then you might go more systematically through it. That's the appropriate way. But you may also inappropriately sometimes not have this, like, this police dogging system 2. So when you're going through your systematic, when you're in triage and go through the ECGs, then you might not have it as an effective policing of your system 1 if you're tired, right? Or if you're in the end of the shift. So the later it is in your shift, the better it is to kind of ask someone if you're having doubts, or keep up, like, the basics, like eating and resting in between shifts and so on and so forth. Well, I've talked a lot about that in other lectures, so I'll move on. Let's start with the systematic approach. This is the part 1, and we'll go through in part 2 these. So part 1. Here's some of the basics in the ECG interpretation. I always find it very, very helpful to go through these, because if we don't, I often find myself to have to remind myself of these. So if we have a rate of the ECG of 25 millimeters per second, then one small box is 0.04 seconds and 1 millimeters high, meaning that the big box will be 5 times 0.04, which would be 0.2 seconds. And they will be 5 millimeters tall. Don't think about millivolts, which some of these pages will always talk about. We talk millimeters. It's important to know that, well, millimeters is an absolute. So if there's what you call low voltage, then what our criteria for STEMI, for instance, which would be 1 millimeter, might be like diminished because well, there's low voltage. It's still 1 millimeter because it's an absolute criteria, and that's what we see, and that's why we partly want to introduce the OMI criteria, because an absolute rule like that is it's a problem in a world where voltages differentiate. That's just one of the reasons why we want OMI criteria. But and the OMI paradigm, but it just at a really basic level, it seems stupid, or not stupid, but it seems illogical. And you will see, like, especially in the inferior elites, that where usually there's low voltage as a default, you'll see that the ST elevation is below the STEMI criteria, even though it's obviously a STEMI by other measures. Okay. Then we go to these intervals, right? So we have your P wave, the depolarization of the atrials. Then you have your QRS complex, the ventricles depolarize, and you have your T wave, right? Your repolarization phase, and all these intervals have a specific length that they need to cover, that they need to, like, be not under or over, and I've mentioned them from there's like different references to reference different numbers, but it's good to have such some kind of view about this. So for instance, the PR interval should be around 0.12 to 0.2 seconds, meaning 3 small boxes, the P to the R here, right? And so on. So some of these are more important than others, right? The QRS complex is very important to know how wide that should be, and it should be no more than 3 small boxes, or 0.12 milliseconds. Because if it's wide, then we'll talk about that later. It will be, we may think of pathology in terms of dysarrhythmias or hemi blocks or bottle branch blocks, right? For instance, there are other pathologies as well. Another segment that is important to know about is the QT, from the Q until the T segment here, where you see the downslope of the T wave, the cross section with the isoelectric pattern, isoelectric line. That's where you measure the QT, and then you can use some formulas to calculate the QTC, so you correlate it to the frequency of the ECG. We'll talk about that later. All right. Yeah. And just to show that there's, depending on the model that you'll see different. I said 0.12 for pure intervals, and the above is 0.2, so 0.12 to 0.2 seconds. But you will see different definitions. But some around that ballpark is important. I think this is a sharp interval, though. I think 3 small boxes is a good way to think about that. Okay, another basic thing that I often think is quite hard, and people use this terminology as if it's really easy, is the concept of the terminology and the nomenclature of the QRS complex. So we can see here that the first downward wave is called the Q. Then the next one is the upwards one is called the R, and then when it goes below again, it's called the S. So that's the normal QRS. But there's all sorts of differences here, so that's why we need to know this terminology. So if there's no Q, then the first wave upwards is still called the R, right? So here, for instance, you have an R, and then you get the S, but you have no Q. So RS. Sometimes this one goes let's see, this goes up again. So RSR, And this is something we see in, for instance, in right bundle branch block or left bundle branch block in V6. So if the wave doesn't go below, like if you have the R, the first one, and then it doesn't go below, then it's called like an R prime, I think it's called. So it's all about when the sequence of waves are crossing the baseline. So the first one is called the Q, next one is called the R, and then the S, right? But I think this illustrates that there's variety, and we need to kind of know what we're talking about when we talk about this. So that's why I made this slide. All right, then the electric road of the, or what we're actually measuring in the ECG is, we talked about briefly that, sorry, that the depolarization of the atrials is the P wave. Then comes the depolarization of the QRS, the depolarization of the ventricles, that's the QRS, and then the T wave is the repolarization phase. There's much more detailed diagrams of this, but I like this one because it shows us that the Q wave is the small depolarization towards V1. So we see that in V1, we have a small positive deflection. So vectors that go towards a lead will make a deflection, positive deflection, and away from a lead will make a negative deflection. Because the ventricle and the septum here is not as muscular as the rest of this, you'll only see a small deflection usually in the V1, like a small current moving that way, and after that you'll have a big current moving the opposite direction, right, down there. And you'll see when you move across the chest from V1 to V6, you'll see this at as you see this from different angles. In the extreme, the V5, V6, you'll not see this at all. You'll not see this part, the right ventricle at all. You'll only see the big left ventricle. And this is what you call R wave progression, because as we just talked about, the first one up is called the R. And you see a bigger and bigger R as you come towards the positive vector here against your lead. And what you might see, and I cannot always figure out this in my head. I think it's really hard, but I know some of my colleagues and some cardiologists, but not all, who can do this in their head and see, oh, but I know which lead is the problem because the voltage should go this way and this way. But this is the basic work or the basic theory or hypotheses for this. What we could mention here is, as well as, like, if you have, let's say you have right ventricle hypertrophy, then this wave would be much stronger, right? And what we see then is that we have a big, as we'll talk about later, you have a big R in V1, which shouldn't be there, right? And we will have a big S because of the bigger current now moving this way. So it'll annul or at least balance out the bigger current from the left ventricle. So normal times the left ventricle should be the big one, right? And the right one should be the smaller one because of the pressures in the systems. But with a high pressure or over time, which leads to hypertrophy, or an acute highly strained situation in the right ventricle, you might see patterns according to that. All right. We need to talk about the different ECG patterns and the different ways of looking at these ECG patterns, or the different ways of constellation for ECGs. So the standard international ECGs, which I am used to from Denmark, and you all probably are used to from looking at international blogs or ECG books is this standard ECG. What we use in Sweden, and I think in Cuba and maybe Japan as well, is what you call the Cabrera ECG. And I used to hate this. And I still think that when this one is so popular, we should at least be able to convert this on our computers to the Cabrera. We should be able to convert between the two on computers, right? Then there wouldn't be any discussion. But at least at our hospital, we cannot convert. So I've had to learn this as any doctor who comes to Sweden, and that's okay. It's much more logical, as I'll explain, and I think that's the strong side of it. That's why we remake the system now. We should probably be using this ECG. I do think though that the potential benefits of this are, I think they're bigger, but I do think there's a big problem with, we know this and we know some gestalts from this. I know where to look. My eyes look at certain places at this ECG. And I also know like the rhythm, like the 25 millimeters per second is not throughout these ECGs. This is 50 and this is 25 down here, as we'll explain. But so there's different, your gestalt gets really problematized when you go over to the Cabrera in the first many years that you're looking at it. And when I do courses internationally, we use these ECGs, and almost inevitably our participants think it's kind of weird that we're doing this one. And I can wholeheartedly agree. But for the reasons I just mentioned, I think we should at least be able to look at both of them in computers when we go to Sweden and vice versa. But let's see, why is the Cabrera ECG so important? And I think we can learn a lot about interpretation of the ECG by knowing just a little bit about the Cabrera ECG. All right, so if you want to learn more about this, there's a Läkartidningen article about this. I think it's also in English even. And there's four major changes that you should know as a newcomer to the Cabrera ECG. The first one is that all of these leads here are average, meaning that you don't get what you call the rhythm strip down here. You get an average ECG, QRS, PQRS-T, made up of maybe 10 or 20, I don't know how many, ECG, QRSs, right? So if you have a non-polymorphic ECG, then that's all right. But if you have a polymorphic ECG where the QRS complexes are different each time, then you will get some kind of average, and that's less good. But if you have in most cases, you have some noise, that'll be canceled out and you'll get a crisp, good-looking ECG. So I think that's the reason why they did it like that. Then you have the lead. Then you have the. Sorry, I'll jump to this one first. Then you have that this up here is like what it always looks so wide to me, and that's because this is in 50 and not in 25. 25 millimeters per second down here, 50 all the way up here. And some of the ECGs also have 12.5, as I'll show in the next slide. So we need, when you're calculating the rate and when you're using your gestalt to see whether or not this is wide, remember I said the QRS is 3 small squares down here? Well, this is 6 small squares now, right? And everything is double. The reason why, and I can see some articles mentioning this is good for certain interpretations where you can't see the small things, such as if you want to see an epsilon wave, for instance, it's better to have it in much more zoomed in like this than having it in 25 or 12.5, right? Then you have the bigger, now onto the more meatier thing, which is the lead presentation. So this is from the article referenced here. So when you have the normal in ECG, then it looks like this, right? it's logical because 1, 2, 3, AVR, AVL, and so on, right? It's somewhat logical, like in a alphabetic kind of way, but it's not logical from an electrophysiological standpoint. And that's the like the greatness of the Cabrera, I think. That is you see the heart from, just like you see the precordial leads from 1 to 6, then you see the other leads from above to below, right? Which is not what you see here at all. So here you can kind of follow the neighboring leads. So that's why they have AVL up here, and they have number 1, and then they have minus AVR, 2 AVF, and 3. So there's one more elephant in the room, and that's the AVR. So in normal ECGs, AVR is way out here, the lone lead, and here they've made it minus AVR so that it's like it's a straight line here. They are neighbors now. Just bear in mind that when you're doing minus AVR, AVR is one of the important leads to know of reciprocity. So if you have a ST elevation in lead 2, then you would suspect ST depression in AVR, right? But in minus AVR, it would be a ST elevation as well. So you don't see reciprocity as a mirror, you see, but it's still reciprocal, but it's just, you just need to double negative it. So that it's not up here, it's not down here, it's just up again, right? And there's one OMI criteria, which is ST elevation in AVR and diffuse ST depression everywhere else. That becomes ST depression in AVR, in minus AVR, and ST depression everywhere else. So there's some small things and gestalts that you need to switch if you can. Just a fun thing. I don't think it's totally appropriate, but they kind of argue that if you have an X-ray that you would build like this, then the X-ray would look like this. So it's much more logical to have it from top to bottom. I think it's funny, but all right, just a small another thing here, and this is still in 50, but this is in 12.5, right? So we'll go through a rule in a little while. That is how to calculate the rate, and the rate in this would be the RR interval from here to here, which is like 2 small boxes, I think. And normally you will divide it in 25 millimeters per second. You will divide it by 300, but here you will divide it by 150. So that would be 150 divided by 2. That's around 75, right? Or that is 75. And same goes if you ever see a 50 millimeters per second, then you have to do 600 divided by the RR interval to get the frequency. Okay. Another basic thing about the ECGs is artifacts, right? So down here, that doesn't look very good. That's almost a sine wave, right? Or Toussaint de Points. But these ECGs looks good, and everyone who's ever looked at a telemetry knows that, well, it doesn't really, like, you need to look at all leads, and because the ECG is being taken like that, it's going from, like, this is the same time, this is the same time, this is the same time. So if this is not correlating with this or correlating with this, then, well, then this is an artifact. This is not a true VT or white complex tachycardia. This is just noise. However, if it was all the way through here, then that's another thing. You can have, just to be clear, you can have things here that are strange VTs, and then around here it becomes normal. That's just because, well, the time, this is time 0, this is time 1, this is time 2, this is time 3, right? So if you have at time 0 have a strange pattern, then, well, that's possible, and the rest will be, if it is normalized by time 1 or time 2, right? All right, moving on to the systematic approach for ECG interpretation. So we teach the OPQRS, and you can use any other kind of systematics as long as it just goes through the more important stuff. So the O is the rate or overview. So as I just mentioned, you can, if it's a regular rhythm, where the regular meaning that the QRSs are spaced out with a stable pattern, then you can use this one, 300 divided by the RR interval, right? Number of boxes between, so 300 divided by 2 big boxes would be 150. And we just mentioned it's different depending on the speed of the paper. If it's an irregular pattern, especially if it's very irregular, then it can be hard to calculate it by this formula, and then you could use it, use this one where you count the number of complexes between the 30 large squares and then multiply it by 10, because 30 large squares is 6 seconds, and that would become 1 minute, right? And then you have beats per minute if you do that. And then if you have AV dissociation, then you have to measure also the P rate and the QRS rate, right? So usually you'll see a QRS rate maybe of 30 to 50, a junctional rhythm, and you'll see a P, maybe an atrial rhythm of maybe, or frequency of maybe 150. Then the rhythm, whether it's regular or irregular, right? And the most common rhythm is irregular rhythm is the sinus rhythm, right? It's when you see the QRSs are being spaced further apart as you breathe in and out, and then it comes back when you breathe in, like so it goes with your breath. And then you have something called irregular if there's no pattern to the irregularity, right? So in sinus rhythm, the sinus arrhythmia, there's a pattern to your breathing in and out. You can see the spacing in between becomes narrower and then wider and then narrower and then wider. But if it's irregular, then it's random, and it's almost pathognomonic for atrial fibrillation. When it's random, there's no pattern. That's where you count. You take a piece of paper, and then you make 2 markers about that. You mark the QRSs, and you see if they repeat or they just random all the way through. And that's how you that's one of the main ways to diagnose atrial fibrillation, right? And then you see if there's sinus rhythm, right? And the sinus rhythm is defined. There's a bigger definition than this, but the short definition is P wave in front of every QRS complex, usually measured in lead 2. Okay. Then you look at the P wave, whether it's positive or negative or biphasic. As we mentioned, the P wave is the atrial depolarization. So if there's any pathology in the atrium, it might show up in the P wave. I think it's a weaker thing to look at, but you, especially when we have POCUS, but you can sometimes see very positive, very negative, or biphasic P waves, indicating atrial enlargement. All right. Then you have your P. Sorry, it's very rare that you only find this finding and nothing else. I think it's almost redundant sometimes, but it's mentioned in the books. So if I skip anything, that's one of the things I usually skip. And the PR. So we look at the duration, and we may notice the depression as well, because the depression is important if we think of ST elevation, ST depression, because the ST, as we'll mention, is defined from the J point, to the baseline. And the baseline should be measured from the PR interval. Oh, sorry, the PR. But if the PR is depressed, then it may look like the ST is elevated, right? And vice versa. If the PR is elevated, then it looks like the ST is depressed. So and also a depression of the PR is something that you may see in pericarditis as well. So all right, then you have your Q. Your QRS is it narrow or wide? And outside of tachy and bradycardia, then you may think if it's a hemiblock or a toxicology problem, or a right bundle branch block or left bundle branch block. I'll show you the morphology for this later. And then you'll check if the Q waves, are they pathological, meaning that they are more than, they have to be a bit wide, meaning 0.75 little box, which is not that wide, which translates to 0.03 seconds, and they have to be like the R wave has to be the Q wave has to be at least 25% of the R wave. So Q R. So if you have a Q going down, it should be more than 25%. So if it's 1 millimeter, it should be the R wave should be around 4 millimeters or below that to be able to for it to be significant in an ischemic kind of way. There are other Q waves, and we'll look at the Q waves of what we call dagger-like Q waves in hypertrophic cardiomyopathy, which is relevant for our syncope patients, right? Then you look at the R's, and the R, which is upwards, is something about to do with axis as well. Because the axis is usually upwards, but it can be downwards, and we'll go through that later. But in Scandinavia, we have tradition of looking at 1 and 2, but as you'll see in Life in the Fast Lane, they have tradition of looking at other patterns in other countries. Just know that there's different ways of doing axis, but we do it like this. Then you have the R wave progression that we already mentioned, that we look at. Then for S, we look at hypertrophy. RNS is kind of hypertrophy, how we measure that. And you have left hypertrophy and you have right hypertrophy. Left and right ventricle hypertrophy, which should be said. The atrial hypertrophy may be seen in the P wave, right? But the left ventricle hypertrophy is something that there's lots of rules, and one of the one I use and the most popular, but probably not sensitive or specific to 100%, is the Lyon-Sokolov criteria. And the number you have to remember there is 35. If you're HB above 35 millimeters, 35 years of age, then the combined height of the largest S wave, meaning downwards, in V1, V1 or V2, and the largest R wave in either V5 or V6, if they are more than 7 boxes, so I usually just calculate 1, 2, 3, 4, and then 5, 6, 7. Okay, there's more than 7 boxes. That means that I have the hypothesis of this being a LVH. There's some great ECG blogs on EM cases about how to differentiate LVH with and without OMI and STEMI, because that's thought of impossible in some of the guidelines, but it can be done. But it's just hard to tease out, and it's something about I think it's around 15% ST elevation compared to the R wave. But look at the blogs from EM cases; they are amazing at these details. And you have so LVH is usually is a lot of and this is not diagnostic for left ventricular hypertrophy. It's just then you have the hypothesis, and then you have to go do your. There are other criteria beyond that, but if they live up to this, and there's also, this is like V1 to V6 criteria. There's also other criteria, but for screening purposes in the emergency department, I think this is enough. And you don't need to look at the Limleys, but there are Limleys criteria, and there are other criteria once you include a patient for these criteria, then you can move on and do the actual work for this. But all right, then you have RVH, right ventricular hypertrophy, which is, as we mentioned, there might be a dominant R wave in V1 or a dominant S wave in V5, V6, meaning that the right ventricle has become bigger, right, as we saw in the electrical way, the way of the electricity through the heart. The vector towards the V1 suddenly becomes very big, meaning an R wave. All right, and the opposite is true for the V5, V6, which would be an S wave. It might also show in right axis deviation. And I think it's important to mention that the difference between, as I understand it, hypertrophy, which is something that happens over time where the muscle grows big, and strain, which is something that usually happens subacutely or acutely, where the right ventricle or left ventricle is strained, but mainly the right ventricle. And there's some overlap between the criteria, right? So we may see, for acute strain, you may see a ventricle that is not adapted to this huge pressure, and then it's kind of failing. That's what we mean by strain. And hypertrophy is like it's adapted over time with a big muscle now for this, and that both are bad in their own way, but the acute strain and the hypertrophy has some overlapping criteria, such as axis deviation, right axis deviation. You may see that in both, but certain things are more specific for strain than for RVH, and that would be, for instance, RBBB, because there should be no RBBB in these according to these criteria, right? But also stuff like the Kosuke sign, as we'll show later. And you look at the ST segment, you look at the J point, it's measured from the J point, as we'll define in a little while, but it's kind of the QR, and then when the S flattens out, and it becomes it goes over towards the T, and that point is the J point. And then you measure it down to the isoelectric line defined from the PR interval, like the PR segment. So it's not the segment after the T wave that you measure it from. It must be the PR. That's the definition anyway. And here, as we will go through later, you look at, is it absolute ST segment elevation, or is it relative? If there's low voltage or it's inferior leads, then you may not get the 1 millimeter, even though it is a ST elevation. You look at the reciprocals, you look at neighbor leads, you look at the OMI criteria, and so on. We'll go through this. Then there's T waves in the T. Is there inversion? Are they hyperacute, or are they pointed, like in hyperkalemia? Is there Kosuke sign? Like the distribution of inversion of T waves may be important if there's in like lead 3 and in V1 in two different areas of vascular distribution in the heart, then there might be a case for this being a PE, right, instead of an ACS. We'll go to that. And then you have the QTC, which we talked about shortly. Then you have others, and others can be depending on the syndrome. So if you have hyperkalemia, then definitely U waves are important. There are different others that you may look at as well. Okay, now I'll just dive into some of the few details of each of these. So we talked about axis. So when you draw the axis of the heart, then you usually draw this drawing, right? When you have AVL, and in the non-Cabrera you have AVR up here. And so this is the limb leads, and you get the precordial leads going in a 3D picture like this, but not drawn here. So axis is looking at the vector. So the more positive it is, let's say it's a couple of millimeters here, so I'll usually look at 1 and 2. So if you look at 2, then here, and then the vectors would be like 2, and then the vector point would be down here. That is how you kind of measure the vectors, right? And if it's negative in like lead 1, then you are, as a rule, then you're over here somewhere, right? Negative in 1, and then if it's negative in 2, then you have negative, then you are over here, which is called the northwestern. If you are negative in 1, but you're positive in 2, then you move over to the right. If you're negative in 2 and you're positive in 1, then you move over to the left. And this is kind of what I have drawn here. My colleague Salim Rasay from Rebel EM has made this, but I added these figures, which is supposed to show the QRS the QRS, the way of the QRS, which way it's pointing, and that so it's easy to do with your thumbs. If both thumbs are pointing up, then it's the normal lead. In lead AVF or in 2, it's the same almost. If they're pointing like lead 1 and lead 2 is pointing away from each other, then it's a left, right? So positive here and negative here. Then the vector is somewhere up here. That's the left. Yeah, so pointing away from each other, left. Pointing towards each other, that's right. And then both of them pointing down, that's a northwestern. And usually, with something we see with VT sometimes, or lead misplacement, right? All right. Then we talked about the significance of what is a significant Q wave. Here's one definition for that. Again, you'll see different definitions depending on the pages and depending on the guidelines, but they're roughly within the same ballpark. This is not an exact science. This is likelihood ratios, right? So if we look at the patterns, we look at, is it one Q wave in isolation without anything else? Then maybe not. But if it's several in neighbor leads with a good history, then even though they don't live up to these criteria, then we'll still be very suspicious. Okay, then you have left bundle branch block, which is usually this is left and this is right, and the mnemonic is, you look at V1 and V6, and V1, if you have a big fat V in V1, that's what you think of then. Be aware that this is not a Q wave, and sometimes you can be tricked, but there's a tiny R here. But sometimes you may have Q waves that are like big and narrow, that looks very much like this. In the OMI lecture I did, there's an example of it. All right, and if this goes down, then this one must come up, right? As we saw in the electrophysiological way. So this is like a mirror pattern. This is this M kind of configuration. So this is a classical left bundle branch block. Then you have the right, which is this RSR, an M up here, and this kind of saddleback bucket handle kind of thing here. And it's not as unique, so it's kind of, I think the right one is usually harder to find than the left one. If you have, often you have what you call fascicle blocks or hemi blocks, and these are like usually halfway. If they're seen in isolation, these are halfway between, like they're not really this wide, but a bit halfway wide, and they may have it somewhere in between a normal ECG pattern and this kind of pattern that has a left hemi block, usually, as I understand. But once you have one of these, then it's important to check for if you have a right bundle branch block, then it's important to check the axis and the PR interval to see if you have what you call a bifascicular block, which is also really important when you have a chest pain patient, as it may be an OMI, and it's also important if you have a syncope patient, as it may be an important cause for a syncope. And if you have left bundle branch block with chest pain, you should always check the Scabosa criteria. Even if they have pacemaker, it works. We talked about the R-way progression. So from the front side of the heart to the lateral side, we should have this more and more pronounced positive which may be usually max in V5, can be in V6 depending on where you place the leads. But you should see this kind of straight line. Sometimes the 3 can be a bit shorter, which we also see here, but it should be more or less like this. If you see that it goes down and then comes up, then it's on EM cases for RA progression, they do have a run through of the differentials for RA progression. I think this is, without chest pain, a weak sign, or without risk of ischemia or a history where you think it might be ischemic. I think this is a weak sign. But if you do have a patient who has chest pain or other ACS atypical features, and you are suspicious of it, then I think it may be more important. But check out EM cases, RA progression, ECG block. One definition of what poor RA progression is again, this is an absolute criterion. Like the STEMI criteria, I think the absolutes are problematic because, well, if there's low voltage or you place it a little bit different, then it's not below 3 millimeters. But this is one of the, if you have an R wave in lead V3, I didn't write that, but if this is the R wave here is below 3 millimeters, then that could be counted as poor RA progression. There's different criteria for that, but usually we want to look at that line, and if it's like here, very obviously bad, then that's poor RA progression. The LVH criteria, here it's the Lyon-Sokolov criteria, more than 35 years of age, and then I already ran through these. You can look up this on EM cases for details, but in general, they have a great retrospective study there as well that tells us that if the QRS overlap with each other in the precordials, then that's as sensitive as this. I think there's a deep dive to be done here. If you want, please do. I don't think this pattern is so important that we need a deep dive for this. We need to know one of these criteria. I think the Lyon-Sokolov, which EM cases endorses, I think that is a good one to know, and then you can always deep dive if you want to, but I don't think it's important in emergency medicine. We'll talk about in the syndromatic ECG, we'll talk about a bit more about OMIs, but hyperacute T waves are important to know about. So just nuance here, the T waves can be either pointy. If they're pointy, like you don't want to sit on them, like then they are usually hyperkalemia, narrow and pointy. But if they're quite broad-based and you want to sit on them and they're relatively really big, then they're hyperacute. And hyperacute meaning imminent, or I think it's mainly reperfusion actually, but it's also partly imminent OMI. So really important sign to know. Mattu has this lecture on rebellion with this link where he talks about that this is the criteria that we usually know, that if you have a QRS that can fit inside of the T wave, meaning that, so here's an almost normal, I would say, QRS complex with a T wave, but here you can see the ratio between the QRS complex and the T wave is so different, right? So the QRS complex can fit inside, and also here. That would be an hyperacute T wave, and also you can see it's broad. It's a bit peaked, but it's more like broad, and you can sit on it. Then the other thing that Mattu mentions is if it's too straight in the initial part, then you should also be worried for the hyperacute T wave. Then you have other T wave like syndromes and something about the T wave, and they're not necessarily T wave problems, but somewhere the T wave looks a bit funky. And this over here is very is very infamous. It's called the De Winter syndrome, right? The Winters. And you see here that you have an ST depression in the precordials, usually V1, V2, V3, I think. And then it goes from this ST depression up into a peak T wave and then down again. This is like a widowmaker kind of. I think it's an LAD. It's a high mortality ECG, right? So it's an OMI. Another special mimic kind of is the Wellens wave. So the Wellens wave is this biphasic T wave. In the also the I think it's V1, V2 precordials where you have up and then down, and this entire thing can be pulled a bit down so that it's a type 2 where you only see almost not the up part but you see the down part. I always thought that this looked a bit like the Brugada syndrome, which we have down here, the Brugada type 1, where you have, I think it's 2 millimeters, it has to be, of ST elevation, and then going down into a negative T wave. So you do kind of see, so there's no ST elevation here, but there is here, and I guess that's the difference. This is a type 2, and this is a type 3, and we'll go into that later. What's the difference? Then you have T-wave inversion that we also look for in the T-waves, right? And T-wave inversion, as I mentioned, if you have a T-wave inversion in V1 and in lead 3, then you have two territories. So if you have a patient with chest pain and you're wondering, is this ACS or is it PE? Should we go to cath lab or should we go to CT of the pulmonary arteries? Then definitely it's highly specific in his study, Kosuge Japanese study from 2012, 2014, I think. That's specific for highly specific for PE. All right, then the QTC, and this is one of these, another thing that where QTC is quite vaguely defined, right? It really depends on the presentation of the patient and how fast it develops or prolonged, or if they're if they have risk factors such as potassium and magnesium problems, such as medication and so on. In general, this write-up is from Dr. Smith's ECG block, which I think I forgot to mention in the references, but it's another really, really great reference if you want to test your knowledge in ECGs, and he has these really in-depth blocks on every ECG. Mattu has a similar site, but Dr. Smith has been a proponent of the OMI criteria for a long time, and he's the author of the OMI manifesto along with some of his colleagues. He also had videos on his Dr. Smith's blog on OMI, so please check those out if you're interested. He updates it, and he also has a running literature list of the evidence on OMI. But about QTC, he also has this. There's this rule of thumb that says if you have your R and your R interval, and then take the middle of those, and then if your T wave is on the left side of that, then the QTC is normal. There are several articles saying that is a it's a normal rule that is used quite often, but it's also a rule with problems, especially. So that is what Dr. Smith talks about here. It's good if it's normal frequency, specifically 62 to 66. But if it gets much more than that, it will be a more conservative estimate, and it will overestimate the QTC. If it becomes really bradycardic, then it'll be falsely negative. So be careful of using it, especially in bradycardia. You can read the write-up here, and also Life in the Fast Lane. There's even an article here from and also of emergency medicine that talks about how specific it is or how unspecific it is. And they conclude a poor rule of thumb, right? They don't think it's a good test. Depends on the situation, I guess, because they usually talk about toxicology here. And in toxicology, yes, then you probably should use a nomogram or something like that, or some of the calculators. But there's problems with the calculators as well. So like a golden standard for this, well, please comment if you know. But I'm not quite sure that there's one size fits all for the QCC measurement. It really depends, and that's why I guess it's so elusive and problematic for people. All right, so when we're in doubt, when it's bradycardic or tachycardic, especially, or if it's a toxicology case, we probably need to measure it out. And how do we measure it out? Well, on MetCalc, there's a great calculator. It depends on what kind of. There's all sorts of theories on what kind of formula you should be using and which kind of frequency, Frederick's or Frederick's formula or Bassett's formula and so on. But let's go beyond that and just say this is how we measure it, and then you can make up your mind yourself on which one to choose. So it's the intersection of the maximum slope of the T wave and the isoelectric line, right? So here's the isoelectric line. Here's the T wave, and what you see here. So this is where you measure it. So from there until there. This is a U wave, all right? So the problem with U waves is that they should not always be incorporated, but sometimes they should. So if it's a small U wave, you should not. And if it's a big U wave, you should. And I'm not sure about the definition. Maybe it's buried in this article here, where I got these pictures from. But in general, if it's a big U wave, you should count it as a QTC. If it's not, then you should not. What's the upper rate? I mean, some references would say that above 500 milliseconds, it will be a higher risk for Torsat de Pointes. But other references would say that normal is around, depends on if you're a male or female, but I think it's 450, 460. 440, 460 is kind of the normal, abnormal Bell's curve rate or measurement. But then above 500, it becomes dangerous. It begins to become dangerous. And then there's I guess, kind of dose response curve there. But I'm not sure how linear it is. All right, so if we use all of this when we go through the ECG, now I've shown a Cabrera ECG. Apologies for this, but so rate. So how many small boxes are there here? Let's see, 1, 2, 3, 4, 5. So this is a 25 millimeters per second. So 300 divided by 5 is 60. So this is a frequency of 60. The rhythm is, so we have the PQRS, PQRS, PQRS. It's a sinus rhythm. The P waves looks like to be positive in all leads and not exaggerated. The PR interval looks normal. It's less than 3 to 5 small boxes, or is it within 3 to 5 small boxes? PR here. The QRS is less than 3 small boxes. It's narrow. There's no Q waves, and not even insignificant Q waves. The axis is, so this one points upwards. There's a small S wave there, but the concordance is, sorry, not the concordance, but the dominant QRS complex is mainly positive here. So that's what you have to counter if the S wave was a bit as deep as the R wave is tall, then it would be isoelectric, right? And then it's kind of almost right if right axis if this one was positive. But these are both positive, so both positive. That means that's a normal axis. R wave progression. Let's see in the number 3. it's one of these where it's a little bit lower than in the 3, and I think but it's not below 3 millimeters, and it just goes, let's see, 2 boxes, around 2 boxes, more than 2 boxes, and then peaks here. It's an okay RA progression. I'm sure it's fine, and that's why it's kind of subjective, the RA progression, oftentimes outside the criteria. But I would say it's normal RA progression. Hypertrophy, well, you measure the left hypertrophy in the precordials, at least. It's like, so how many is there? 7 boxes from the deepest S wave. So let's see, 1, 2, 3 big boxes here, and let's see, 1, 2, maybe 2.5 here. So that's 3.2.5. That's 5.5 big boxes, right? And that's 25. That's 27.5 millimeters, and this should be 35 millimeters. So it's not hypertrophic, and you can use these over here, but I usually don't. Then you have right ventricular hypertrophy, and that's a dominant R wave here. There's no dominant R wave, and there's no dominant S wave. A lot of these criteria, right? If I do screen the ECG and it looks kind of weird, then I have to look at the life of the fast lane to check the criteria. So that's what I suggest to you. I don't go around knowing all this stuff in my head, just the screening criteria, right? All right. Then we move on to the ST segments, and I think the ST. So we can never interpret an ECG in isolation, right? We should always think of the context and a pretest probability. So what I'm doing here is sacrilegious. So when the nurse comes to you, you always want to know what is the patient's symptom. Is it loss of consciousness? Is it chest pain? Is it ongoing chest pain? Is it ingestion of toxic drugs or so on? So, all right, but here we're going blindly. This may be just a screening ECG because it really looks normal. Yeah, all the ST segments looks normal. When we look at the reciprocal, so 3 is reciprocal to AV and 2 is reciprocal to AVR. It doesn't look like there's any reciprocal changes, and 1 is reciprocal to V6. And then you can look at, I usually now go on to look at some of the OMI criteria, but I don't see any OMI criteria, and I only use them especially if I'm suspicious of an OMI, right? So usually the chest pain patient or the dyspneic patient mainly. All right, then we look at the T waves. And the T waves, I forgot to mention, should always be concordant to the QRS. So if the QRS dominantly is upwards, then they should always be upwards. And negative T's are usually seen sometimes in lead 3 by baseline. There are some places where there might be an inversion that is kind of within normal variation. But as a general rule, the T wave should be kind of in the same direction as the QRS, the brunt of the QRS complex. You do have something that I didn't mention, which is called pseudo-normalization as well. So you may, let's say that you have this normal variable finding where you have a negative T in lead 3, and then the patient comes into you with chest pain, and now it's normal here. Well, it's normal if we have never seen the ECG before, but we now know that the patient didn't used to look like that. So that's called pseudo-normalization. Mattu talks about this. Sometimes, like, what we think is normal depends on the previous ECGs, right? You might call that, this might be within the concept of dynamic ECG changes, but it's just something to know about, like pseudo-normalization, it's called. All right. Then you have, sorry, the QTC, and as this is normal frequency, then we can just kind of use my rule here, R to R in the middle, and then the T is on this side, or the isoelectric line with the T is on this side. That's good. There's no U waves, and there's no other things to look at. Okay. So in conclusion, that was a normal ECG, and that's the systematic approach. I think with a bit of practice, it's quite easy to go through this, and this becomes kind of system one. Usually, I forgot to mention, I look in lead 2. But of course, you need to look at all the leads for pattern recognition, but stuff that is in one lead should also be in the same, in the other leads, right? But usually, at least to if all, as we mentioned earlier, if all leads are taken at one, like time 2 or time 3, then all things in time 3 should kind of exist in all leads. It may be buried in some of the leads, and that's why usually lead V1 and lead the extremity lead 2 are usually the ones that are easiest to look at, to see things that you need to see. All right, then we move on to the syndromatic approach. So we don't always go through the hypertrophy criteria and so on in all these ECGs. There are certain things that we hone in on when we see a patient. And this is what leads us to different syndrome management in terms of ECG interpretation. So let's look at the different syndromes and go through some details. So let's first look at the chest pain OMI. And a lot of this I've already gone through in the OMI lecture, but that's a 2-hour lecture, and I'll just go through some of the summarizing features here. So what do we look for when we have a patient we may think have an ischemic chest pain or ischemic symptoms that may be atypical, but like rarer dizziness, but more often dyspnea, especially in older women with diabetes or neuro deficits. So we look for Q waves, right? We look for significant Q waves. As we mentioned before, what the definition is for that. We look for ST elevation or depression in neighbor leads and in reciprocals and so on. We look for the hyperacute T waves. We look for inverted T waves and the pattern of inverted T waves, COSAG and so on. Maybe pseudonormalization and biphasic T waves, such as the Wellens. And we look for special stuff like the OMI criteria, right? Such as the Winter, such as Wellens, such as Scarbosa positive LWB, and so on. We'll see that. And I always stress the importance of these things here. So ST segments are not an absolute thing. I know the ST criteria wants you to think that, but it's not. That's why we want to move to the OMI criteria. So 1 millimeter of absolute ST elevation. Yes, but if it's low voltage, or it's especially the inferior leads, then it may not be 1 millimeter. Sorry. Then we look at the reciprocals. Even if it's not 1 millimeter, then the reciprocals may indicate that it's definitely something going on. If there's a inversely depressed area where the main lead is ST elevation and the reciprocal is ST depression, and that's a problematic one. Then we look at the neighboring leads, right? And that's where the Cabrera ECG is quite good, because they add up they line up the extremity leads, so we can see which ones are neighbor leads. And we want to, in the perfect world, we want the history and the vascular territory of the ECG to fit with our POCUS hypokinesia as well. And that should fit with the PCI diagnosis, right? Just like when we do neurology, where's my lesion? But it's not, as I understand it, this is not as perfect a 1-to-1 ratio. There's a lot of variability in the heart and the vascular territories of the heart. And it's not always that the ECG vascular territories looks like what we see when we do the PCI. Okay, then we also always have to think of the temporal aspect. We take an ECG now that might be non-significant STEMI criteria, But let's take a new ECG in 15 or 30 minutes, especially if they still have ongoing chest pain, right? Then we can see the dynamic changes. We can see the progression or the reperfusion of the ECG, which we would call dynamic changes, right? We also always want to look at the early ECGs if we can. That's like a cheat code, because if you can just have the two ECGs right beside each other, and you look through the systematic way of going through ECGs, then you can kind of quickly just say, okay, looked unchanged from earlier on. Okay. So I mentioned that we measure ST elevation from the J point. So the J point is where the S wave goes up and meets the not always S wave, but the QRS complex becomes flat at some point. And when it becomes from slope to more horizontal, that's kind of where it is. That's the J point. And you can see the J point looks differently in different QRS complexes. And then you measure down to the isoelectric line defined by the PR segment. And here we see if the PR segment is lower than usual, such as in pericarditis, then you will see that it looks like there's an ST elevation, but there isn't, right? So if you measure it all the way down here, then there would be a significant ST elevation, but there isn't, because this is just the PR segment that's lowered. Okay. Just as a small test here, or you can see how I think ST elevations in these ECGs are quite tricky sometimes, unless unless you've been practicing, right? So if we just jump to where the money is in this ECG, well, there's the frequency of like 1, 2, 3, 4, 5, 300 divided by 5. Is 60. And what we see, just the configuration here is the left bundle branch block configuration with a fat V in V1 and M configuration in V6. So the Scarbosa criteria, there are 3 Scarbosa criteria, right? There's one where there's an ST depression here. So the ST depression in V1, V2, V3. So the J point is there, the J point is there, and the J point is there. So there's no ST depression here. Then you have the second criteria, which is a concordant. And here comes the concept of concordant, discordant. So concordant meaning that in the same direction as a QRS complex, there's an ST elevation. So this is what we see, for instance, here, here as well, and maybe here as well. And definitely here, because this is also concordant, it's just the opposite direction, and this is concordant here, so that's reciprocal to that. And this is reciprocal to that. This is definitely OMI. But so that's the second criteria. That's one of the criteria as well, like 1 millimeter of concordant ST elevation. The last criteria is more than, like, the ST segment should be less than 25% of the either the S wave or the R wave, depending on which direction the QRS complex is heading. So here it's a bit hard to see in this one, but here's the J point and maybe 1 box there, and then there's 3 boxes here. So it's maybe here and maybe there, maybe above. What do we think? And maybe here as well. So V2 to V4, I would like to look in a zoom lens on those, because they might be filling. They might be this not appropriate disconcordance. So concordance, QRS, and ST elevations in the same direction. Disconcordance, QRS this way, ST elevation here, and we talk about what you call non-appropriate disconcordance, like the ST elevation is way too big in relation to the QRS, sorry, the S wave here. Yeah, so that's the Scarbosa criteria just quickly. And of course, if the patient was hemodynamically stable, unstable, it didn't matter. Then they were out the window, and we go to PCI no matter what. All right. Then we kind of then we look at the OMI criteria, right? So, and I made an entire video about these, so I'll not go through these, but you just check them off, right? The classical STEMI, where you have in V1 and V2, there's a bit more millimeters to be had, depending on whether you're a woman and depending on or man, and depending on the age. But otherwise, it's 1 millimeter of elevation in 2 neighboring leads. You have your left bundle branch block with Scarbosa positive criteria. You have your right bundle branch block with then left deviating axis, which means that you have a bifascicular block, and that might also be one. You have your inferior wall STEMI and your RCA STEMI. These are usually low voltage and don't live up to the STEMI criteria for 1 millimeter, but they have reciprocals that tell you otherwise. Your posterior STEMI is a STEMI equivalent that has long been recognized with a ST depression in V2, V4. High lateral MI with depression all over and positive ST elevation in AVR, or a ST depression in minus AVR, right? Depending on whether or not you're in Sweden with a Cabrera, and so on. So yeah. So I'm not going to go through the last ones here, but it just we'll you can check out the other video, and then down here you have hyperacute T waves and Wellens waves and so on. And the winters, I think, is must be over here. Okay, this is the cheat sheet from EMCrit, and you can just Google it and find this. It's also in the OMI videos or in it's in Scott Weingart's RCM book. It's a lot of places, and maybe like when you're doing studies on it, not all of these signs are 100% sensitive for MI, but neither is STEMI criteria, right? And some of them are like better than others. But it also depends on the patient's presentation, right? If you see some of these in isolation, it's not necessarily important. For instance, just STEMI criteria, there's lots of differentials for STEMIs, right? Such as hyperkalemia, pseudo-STEMI. Yeah, these are important to know about. There's this YouTube. I forgot to bring it on here, but there's this YouTube rap video on where they go through all of them in 5 minutes. And if you want to read up on these, just check that out, or check my video out. One takes 5 minutes, and my video takes 2 hours, so depends. All right. Then we have the concept of neighboring leads, and again, this is not the same as neuroanatomy. It's not this 1-to-1 ratio, but it's somewhat in correlation. So you have your inferior leads, you have your lateral leads, and you have the anterior septal leads. And your anterior septal leads, that's the LAD. Your lateral leads, that's the circumflex. Maybe the part of the LAD, and then the inferior is the RCA and or the circumflex. Yeah, and if you just to remind you about the anatomy of the heart and the coronary arteries, then you have going off from the aorta directly, you have your RCA, your right coronary artery going down here, and it's coming out here, right? And then you have your left coronary artery, LCA, which is branching off into two coronary arteries, the LAD. The LAD down here, and then the LCX, the circumflex, which branches on the backside here, supplying the left ventricle. And again, there's huge variations on how this vasculature may look, but this is usually the normal one. Yeah, and as you may see, there's several articles that I've never read or never intended to read about the variation of these arteries, right? And some of them in their own right are low risk, and some of them are higher risk. And also just think about some of them may be intramural, leading to what cardiologists may think is vasospasm, and when the heart constricts, then this may constrict along with it. At least there's a mechanistically valid argument for that, but it's not necessarily correlating 100% to what you see in the daily clinical practice. I'm not sure. I'm no expert in this. Just saying that there's differences, there's variation, and there's some of them actually going into the heart wall intramural, and some of them not. And also you have heart transplants. You have babies with congenital heart disease that have been operated on that might not live up to our own criteria. So just bear that in mind. All right, back to the good old Cabrera ECG here, and this is where the vascular territories may be placed. The RCA is inferior still, the circumflex around here, and then the LAD. And I think these are important, especially if we can correlate them to hypokinesia in the heart, right? So hypokinesia is quite hard to see on POCUS, I think, and it's definitely a next level thing. It's not just basic POCUS. But we may look at, if you look here in the SAX view, the short axis, if you put your finger here on the screen, you may notice whether or not your finger is being squeezed from all sides, and whether or not this musculature is being constricted to a 50% of its normal size in every cycle. Or whether there's global axial movement in the or not. And oftentimes you may, even with novice eyes, see that, well, certain areas of the wall is not moving. So we have this correlation. Chest pain correlated with this. With the right area. Sorry for the color differences here. So RCA would be the blue one here. And then you have a good case, right, to tell to your PCI center, even if they don't believe in the OMI criteria or read different literature. We should never diminish their expertise, right? We should just have an informed discussion with our colleagues about whether or not this is an important thing. And I think according to the new American guidelines, I think this is turning around the OMI now. I think we are getting to where we are talking the same language. All right. Then we have reciprocals, which are important. I already mentioned the three-dimensional axis view here, and well, the reciprocals that we need to know about is the AVL is reciprocal to lead 3. AVR to lead 2, but in minus AVR they go the same way. Then 1 and 6. And then 2 and 4 are reciprocal to the backside, like what you call the V789, which you should probably not use because it's not sensitive anyway. You should usually do serial ECGs or just call PCI if you have a good history and ST depression. EM cases have a great blog on that as well, posterior OMI. So All right, so here I have a ECG from a middle-aged woman with chest pain. Of course, all of these cases are real, but they've been anonymized, so this may be anywhere. So this is a we have a rate of I see 7 small boxes here, so 300 divided by 7 is around 40 and 47. So 42. So it's a bit slow, so bradycardic. But it doesn't seem like I'll directly now go to the PR interval, but it seems like the PR the PR interval is stable. So it's sinus rhythm, I think. There is some noise, and there is a bit of sinus arrhythmia. You may think where the QRS is becoming farther apart and then closer in between, but it may be just the noise of the ECG. I don't see any pathological Q waves anywhere. I do see a narrow QRS, normal axis 1 and 2 here. The R wave progression, a bit low voltage here, but it seems okay. I mean, the tallest R wave, maybe this one is maybe a bit off. I'm not sure, but a little bit off, I think, because it peaks here in 4. It should be peaking in 5 or 6, and the 3 might be a little bit short as well. If you looked at that voltage criteria I showed you, so yeah, maybe a bit bad R wave progression. Then there's no in S there's no hypertrophy because S wave is not S wave plus R wave here is not more than 35 millimeters, or 7 big boxes. And then ST elevation is hard to see because it's really a small ECG, but there might be some subtle changes down here, flattening. I can't see it on my screen totally, but when I looked at the ECG, I remember I thought it might be a little bit subtle, and maybe not much. More clearly, it might be some ST depression here and here, and that we're always worried about posterior OMI here. So with chest pain, ongoing chest pain, we wanted to do another ECG soon with this. There's no T wave inversion though. And then there's a normal QRS, but again, this is bradycardic, so we may be underestimating it. Don't care for the chest pain patient right now. We do another ECG, and now we see some changes here in the ST segment, right? So now it's 2 to 4. Now we're really worried about posterior OMI, but it's also going down to 5 and maybe even 6. We even see some maybe slightly reciprocal changes from the V6. But what now is even though it up until this point may have been this is something that definitely should be looked on, but now there's even this small QRS here can fit into this T wave. I would say this is a hyperacute T wave now then. All right, and we have some T wave inversion in AVL as well up here, and in lead 1. So definitely now progression. And we take the ECG 15 minutes later, and now we have definite inferior STEMI with no OMI criteria here. This is STEMI criteria positive, more than 1 millimeters in neighboring leads, with ST depression in the reciprocals, and even ST elevation here lateral. And we may, especially, I think the lesion would probably be here. I thought to begin with it may have been posterior OMI, but it developed to become this. All right. Okay, and what if we did a POCUS? Then we would think that the inferior wall towards the right side of the heart may be moving less, and We could also, I mean, depending on the history, we may entertain the idea that what if the chest pain was not specifically angina, but more like aortic dissection, like, and we could think of other pathologies for this, right? So the pretest probability and the history of the patient is always important, even though we see definite ST elevation here. It may be because of something else than just an OMI. It might be a Minoka, might be something else, but definitely PCI. And when they did this PCI, it turned out to be an RCA, proximal RCA. That's why we're seeing so many other changes than just the specifics here. And these patients, just to remind you, in the literature, we usually say that they should not get nitro because they're preload dependent, and if you get nitro to them, then they'll tank their blood pressure and become shocked. Okay. That's for the syndromatic approach for the OMI, looking at Q waves, ST segments, and T waves, and also the OMI criteria. Then for the next one, I will be looking at transient loss of consciousness. And in general, if we have a tachycardia or bradycardia, then it's kind of obvious. This is the two segments up here. If it's bradycardia, then we'll look at the PR segment and the P waves for every QRS. If it's tachycardia, then we have these three questions. Is it regular or irregular? Is it P waves for every QRS? And is it wide or narrow? And I've always add some additional questions there. Is it primary or secondary, do you think? We can ask, well, 200, like whether it's primary or secondary is usually a clinical question as well. But as a rule of thumb, either 220 divided by, subtracted to the patient's age, subtracted from 220, meaning if you're an 80-year-old patient, then you should not have a heart rate of above 140. But I do think that the magical boundary for me, distinguishing primary and secondary, is around 140, 50. Like, if it's a much more above 140, 50, especially 50 or 60, then it becomes much more likely for this to be a primary thing. Of course, also the context. If they have high fever and so on, then more likely to be secondary. But sometimes it's both a primary and a secondary. Like, they have a sepsis and they also are going in 180 or 200 atrial fibrillation because of the stress. And it becomes important to treat the underlying cause first, and then after that only give the drugs. But I haven't seen a lot of studies on this actually. I only see I'll show you the atrial fibrillation guideline from Canadian Emergency Medicine organization, CAPE, where they do this distinction, but usually I haven't seen it a lot. So feel free to comment what you do. Okay, and then also I also add the question: is it wide? Is it what Amyloid 2 call RRWCT? WCT is wide complex tachycardia, and R is regular and really wide. So regular, really wide, complex tachycardia. That's with usually a frequency of below 100 to 130. Then you should not usually treat as you usually do. But we'll get back into that. And then if it's not obvious, and the patient presents with a transient loss of consciousness, then I'll go into looking at some of the subtle changes that we may see in ECGs, and we haven't talked about yet. That may be the cause of syncope in young patients especially, and they may lead to death. All right. So bradycardia, you only have to look at the PR interval for bradycardia. If the bradycardia, if there's no PR problems, then it's a sinus bradycardia. You have to look at, is the patient cold? Are they taking drugs like beta blockers and so on? But if it's prolonged and it's stable prolonged, meaning it's always the same then we should think about, well, this is a first degree block. That's all right, as long as it's not symptomatic or seen along with other kinds of blocks, such as right heart block, right bundle branch block, right? Okay, then if it's increasing and increasing, and QRS are falling out, then we should be thinking of winky back or Mobitz type A, Mobitz type 1. And this is so first degree, second degree, these are these two, and then Mobitz type 1, type 2 of second degree. Mobitz type 2 of second degree, that's when you have a stable QRS, a stable PR segment, but then suddenly it falls out, one of the QRSs. And then you have your last third degree one, which is where you have an AV dissociation. So you have, if you measure the if you measure the P waves, then you can see that P wave here, P wave here, and here, and here. So they move in their own pace, and the QRS is a junctional rhythm. But if you only look at the PR segment, you see a long PR segment, then you see a T wave, then you see a narrower PR segment, and then small. So in a small strip, sometimes it can add up to look like a winky back or Mobitz type 2, but usually if you get a longer rhythm strip, you can usually see it. Yeah, and it goes without saying that the above, like you can make a line in the middle here. Above this line, you kind of, like as a rule of thumb, you treat them only if they're symptomatic. The winky back phenomenon is a somewhat physiological phenomenon to help ease the ventricles when there's a lot of activity going on in the atrium. But if they do become symptomatic, then they should also probably be treated. It's up to a cardiologist, but Mobitz type 2 and AV dissociation is always pathological and should always be treated, usually with a pacemaker. I'll get into when you do see a bradycardia, then there's the ERC guideline for treatment, which we'll go into now. But then there was also the what to do about the causes. So there's the causal algorithm is called DICE. So drugs, D, that is that would be all the AV blocking agents, digoxin, metoprolol, and so on, amiodarone. I is ischemia. So do they have a ischemic event? You look at the ECG for OMI criteria and so on. Take troponins. E is electrolytes, and especially hypokalemia in bradycardia is high potassium. Hyperkalemia can produce this kind of bradycardia, and that's really one of the more ominous signs in hyperkalemia. So look out for that. And then S is sick sinus syndrome, and there's others as well. We'll go through them now here. So first 10EM has these great Fui's figures. Sarah Fui, I think she's called, makes these great paper, like algorithm in a picture for these things. And down here you can read the causes for bradycardia. They use the DICE algorithm as well, but they have added a few more. And I think good to mention just that the patient is unstable, meaning that if they have ischemic heart disease, if they have syncope, if they have shock, or if they have heart failure, those are the four what we in Danish call the 4 S's. And then you have to go to just treat them, and we'll see the treatment algorithm soon. But you also have to think of the causes, right? I always like this area here, because it's not often that we transcutaneous pace, at least in my hospital. So it's good to know how to use your own pacer to get electrical capture and then mechanical capture, and how to there are several YouTube videos on how to do this, and it's nice to familiarize yourself with your apparatus and how to do it in your department. Okay. Here's a bradycardia algorithm from ERC 2021. It's almost too small for me to read, sorry, but the general rule, as I remember them, is that it's kind of like you have the 4 S's, as are just like are they in a acute or not acute, and if they're acute, or sorry, if they're not acute, there are some criteria where you should treat them as acute anyway. But if they are acute, then you treat them with first atropine, then second level is isoprenaline or epinephrine. That is kind of the same drug, and then transcutaneous pacing is the and when you do transcutaneous pacing, then you also have to sedate the patient, or at least pain manage them, and always try to go as low as possible in the frequency, which would be like they only need to be 60 frequency, right? If you have a higher frequency, then it's then you stun them more, and that hurts. And also you go for the lowest amount of milliampere to get capture, to get mechanical capture. And usually you go down to you go up to the level where you get electrical capture, and then you get mechanical capture through either your saturation. You can just look at the sat on the saturation, and you can see there's pulse. That's a good trick. Otherwise, you can just measure it with POCUS, or you can see it with POCUS, or you can measure it by old-fashioned manual. But that's always a problem because there's a high insulator reliability. There's a problem with false negatives there and false positives. Yeah. Then for tachycardia, there's these 3 questions that we mentioned, along with my additional, and then you can do this 2x2 diagram. So if you have narrow and regular, then it can be sinus tachycardia. You specifically look for the P waves if you want to diagnose something here. In general, we are not at. So there's always a discussion of how much we need to diagnose here. Usually, the treatment is usually kind of the diagnostic thing here as well. So, but there's sinus tachycardia, there's atrial flutter, there's AVRT and AVRT, and there is this called EAT. If it's narrow and irregular, meaning that they don't come at the same time, the QRS, but they come a bit more randomly. If there's irregular, then it is almost always atrial fibrillation, right? It's totally random. But if it's irregular to a point like 1, 2, 3, and then a pause, and 1, 2, 3, then it's irregular, but it's not irregular. And it might be something else. But in general, it's almost always atrial fibrillation. There is atrial flutter with varying AV block and MAT, but these are more rare. Then you come on to the wide and regular, and the wide and regular is monomorphic VT, or it's regular SVT with aberrancy. And the regular SVTs are these, and if they have an aberrancy, for instance, left or right bundle branch block, it may be SALT syndrome, like a toxidrome, or so. It might be something else that makes something that makes the QRS wide. Well, then you have a case of SVT with aberrancy, but as we'll go into, it's hard to distinguish these two. And then you have your polymorphic, meaning that, so you have both irregular, meaning that they don't come at the same time. They come randomly, or at least if they come non-regularly. And the QRSs, and then you have the polymorphic. It means that the QRSs are a bit different every time. And of course, just again, you can have an irregular, like an atrial fibrillation, and then with aberrancy again here. Same aberrancies as up here. So that's kind of if it's wide, is it primary or is it secondary with aberrancy? It's nice to just put this here. In general, you should not give AV blocking medications to Wolff Parkinson White with an AFib. They usually, so an AFib is usually down here or up here if it's an atrial flutter. They will be wide because of the WPW. And they will look irregular, right? This is what you call snowflake ECG, but it can be hard to distinguish that from a VT. And as we'll go into, some of the guidelines will want to give adenosine even to these, or AV blocking agents even to these. Traditionally, it's only been these, but now even these. And that's the main problem for that. And then also, if you have these are real, like regular, really wide complex tachycardias, or WCT as Emil Mattu calls them, you should not give amiodarone because they will die. And that's important because the default, instead of giving the electricity to these, would be to give the medical conversion. And the problem is our WCT will fit into one of these, and then you give them amiodarone instead of electricity, and then they will die. That's why you always have to think about that. Okay, so here's if they're stable. Again, if they're not stable, then you could just give them electricity. But if they're stable, that's where you come into the diagnostic thing. And the diagnostic thing is, if it's narrow and regular, then it's usually adenosine. If they're really fast, then it can be hard to distinguish whether they're irregular or regular. So if you give them adenosine and it turned out to, now it slows down, and then you can see that it's irregular. Oh, then there's an atrial fibrillation, or then it's a atrial flutter. And the AVNRT and AVRTs, they will just usually convert if you give adenosine in a big vein, like a cuboidal vein, and you give it a flush dose, and then you can repeat it. I've had a couple of patients with this where they first gave it on the hand, and that's way too far away. And with a much smaller dose, we could convert the patient. And the time they came in to me at my place, not because of my excellence at all, but probably because of, well, you just making the point that you really need it's not, a lot of things just are in books and they just say, oh, we should do it as in the book, but this is one of the things that probably is good to do as in the book because it's important. All right, you can before that do vagal maneuvers. Maybe the REVERT trial, you know that, is where you do this modified vagal maneuvers where you make the patient blow on a syringe and then you put the head down and legs up. All right. Over here, you will, if it's regular, you will get the cardioversion usually, especially if you know if it's a VT. There are different versions. If you talk to a cardiologist, they may say that there's different VTs, and that's true, and you may give different drugs for different VTs. But in general, the safe version is to cardiovert them. If you're in doubt, then cardiovert them, right? That's the usual mantra. And then in newer guidelines, adenosine has become more prevalent because this may, just like this, it may slow it down, and then you can kind of see whether it's SVT with aberrancy or it's VT. Because if it's SVT with aberrancy, then it's really important that you don't convert them, because if it's flutter or atrial fibrillation, then they might have then you're converting someone who is uncoagulated sometimes. So that's the reasoning behind doing adenosine here, with the risk of killing one of these. But if you have pads on, then you can quickly get out of it, get out of the ventricular fibrillation, in theory at least. If you have an irregular wide, then it kind of depends on what do you think is the reason. If you think it's torsade de poing, then you can give them magnesium, and it's important that the toxicity point doesn't always look as the classical picture. So if you have someone who has been, it's always important to take a new ECG after you've converted them and see that they have a QCC prolongation, and then treat them. All right. So just to show you that I think atrial fibrillation is usually a bit hard, a bit tricky, because there's so many things to know about it. And it almost always just leads to NOAC and beta blockers. But there's lots of stuff to know on the way. And I think this CAEP best practice paper is excellent. And I think this algorithm is really excellent as well, from Steele, at showing like the big important things. And I use it in my everyday when I have these patients. There's also on Vimeo on EMU 365 a good atrial fibrillation lecture going through the bits on this. And up here I have from EM cases on tachycarditis. I think it's episode 112. There's a read through of flutter versus fibrillation, and in short, atrial flutter is usually really is easy to cardiovert, but this one, atrial fibrillation, can sometimes be harder. And atrial flutter can be treated by ablation, usually ablation, but atrial fibrillation not so much. It's usually recurrent, depending on their underlying risk factors. Yeah, and chemical conversion of atrial flutter is harder, and atrial fibrillation is easier, right? So that's the differences. Here, I just wanted to point out that it's important when you go into all tachycardias to think, are they secondary or primary? And we already talked about how to distinguish the primary and secondary, but this is the algorithm where they actually talk about it. Okay. So I alluded to this discussion of VT versus SVT with aberrancy. Some sources would just say the safe thing is just to give them shock, give them electrical shock, and then you're out of the problem. But when we talk to our cardiologists, I think they have a good reasoning behind why not always. There's a risk of sedation, of course, by giving a shock, depending on when they had the last meal and so on. But the more common risk, maybe higher risk, is that if you're converting something that actually is an SVT, if it was a flutter or a fibrillation, atrial fibrillation, then you're converting someone who's uncoagulated, and it's really common to have an SVT, right? So that's a problem. On the other hand, the risk of giving adenosine, which is the other way of doing it, to a VT, that runs the risk of, if the patient has VPV and it's an AFib, then you run the risk of giving them a ventricular fibrillation. So have always pads on, right? Our cardiologist would sometimes say that we should also try to do esophageal ECG in order to give even more information on when we're giving adenosine. But what does the guideline say? Oh, sorry, yeah. Can we make the distinction between these two? Well, according to EM cases and Mattu, it's only 90% specific, any of these rules that we have. So we will miss 10% of them if we do. And according to them, it's really dangerous to give AV nodal blockers to these patients. I don't know, outside of VPV with atrial fibrillation, who it's dangerous to give them to, but it seems like there might be more. I'm not sure, and I've never heard about any other cases where it's dangerous, but you can comment if you know it. Life in the fast lane, always the probabilistic get-goers think that, well, you can take a probabilistic approach to this as well, and I don't think it's illogical to do that at all. And there's 5 criteria, the ABCDE, they call them the ABCD criteria. If the axis is northwestern, if there's a very broad complex, if it's concordant, like meaning this going the same way, if there is AV dissociation, you may only see this in esophageal ECG, and there's something on the early parts of the ECG I can't remember. Look at the link. Then you may this very likely would be an VT instead of an SVT. There's even a score for this where a lot of these goes into, and if they have more than 3 points, and it's quite specific. So there's some controversy here between the different blocks, and you'll see that there's also some controversy between the different guidelines, as we'll show now. So this is the old guideline from 2015, ERC, where it's quite like classical, where you have a stable or unstable patient, and if it's stable patient, then you'll go to, is it broad or narrow? If it's narrow, then you give adenosine, and if that doesn't work, or if it works, then you have the diagnosis. If it doesn't work, then you go on, and so on. So here we have a distinction between the narrow, where you give adenosine, and the not narrow, the wide, where you do not give adenosine, where you give other drugs to try to convert the patient, because that's a more safe way of doing it, unless you with quite certainty know that it's an SVT with aberrancy. But how would you know that? We just went through that it's only 90% specific probably. But all right, so that's the old algorithm. Then in 2021 they came out with this one. Again, same concept of if they're unstable, and go to cardioversion or give amiodarone, and if not, here they go on. If it's broad, well, then it depends on if it's irregular now. That's whether it's irregular or regular. So if you have a regular, no matter whether it's broad or not, then the regular, narrow, and wide ones, they all get adenosine, right? And that's I believe for the reasons that I just mentioned, that, well, it's maybe more dangerous to cardiovert an uncoagulated patient than giving adenosine to a VT, on the slim chance that it may be the irregular Wolff-Parkinson White with atrial fibrillation that you have misinterpreted. But again, I don't know if there's any high risk in these, but and the ECS guidelines says the same thing from 2002, that you can give them, if their hemodynamic is stable, then you do adenosine, and then they have a more sophisticated guideline on the VT. But in general, it's kind of the same. And here they have their reasoning, and they write like this: they should not give adenosine to the pre-excited VPV with atrial fibrillation. But how do you know? That's the problem. How do you know that you have that if you don't have any previous ECGs and so on? So they kind of cover their back, or they kind of cover their tracks, or what you would say, but in general, it seems like adenosine for these we're moving into that kind of territory. But then there was the ERC came out with their second guideline, or in 2021 they retracted their old algorithm after critique, and went back to the 2015 version. Or almost the 2015 version, and went away from adenosine to the broad ones, right? So just saying, it seems like there's a bit of controversy in this area, and it's certainly something that is also controversial sometimes when we have these patients in our departments because of different opinions. And in general, I think the wise choice is to just have pats on your patient no matter what you do, so that you can give them a shock if you need to. And I think it's reasonable that we should not convert someone who's not anticoagulated unless they're unstable And maybe we should dive in more to these criteria. 90% specificity on SVT versus VT is maybe all right if we can stop if we can stop converting some of the patients that we don't want to anticoagulate, that we want to anticoagulate first, right? So, yeah, it's a hard discussion, right? But I definitely don't have all the data, and I'm no expert, but it came up when we did our last education in our department where I instructed, and we did a bit of a deep dive in this, and it seems like there is a bit of controversy here. So whether you get adenosine or not, just have pads on your patients when you do it. All right. Here's another Sarah Fui's figures kind of algorithm. All right, and then on to the last bit here. If they don't have the obvious tachy or bradyarrhythmia and the patient has come in with transient loss of consciousness, then I've talked about in my recent neuro video about how to distinguish which features may distinguish seizure from arrhythmogenic causes, and that's part of this as well, but we'll not go into that right now. Just know that lateral tongue bites, post-ictal phase, and some semiological features such as open eyes are quite specific for and the duration of 1 or 2 minutes is quite specific for seizures. But oftentimes they don't have these features. They are because they're not sensitive. They're just specific features. So if they don't have these features and you're it seems more like an arrhythmogenic cause, then you of course do your assessment whether or not it's high risk. It has a lot of red flags, like there was no prodrome, or there's family history of sudden death, or so on and so forth. And then you go into and look at your ECGs, and before sending the patient home, then you look at the ECG with these 5 to 6 subtle findings that you need to look through. And this is both Mattu and David Carr's methods, and you can, for instance, check it out on USIM's Vimeo or David Carr's Vimeo site, or the EM Cases episode on syncope with Dr. Carr. Okay, so you can remember them as a QRS complex, or a PQRS-T complex. So you have the blocks, that's the PR interval, that's the obvious ones, along with the tachycardia ones. And as you go along, then the first thing you come into, that's the Q. The Qs, if they are dagger-like, really going far down here, dagger-like, narrow Q waves here that are really deep in the inferior or lateral leads, then think of hypertrophic cardiomyopathy. Then you go on to your VPV, see if the PR interval is shortened. And then you go on to the other side of the ECG, the QRS, and where you have the opposite, what you call the epsilon wave. And it's called epsilon wave because you have a delta wave here, and then on the other side you have epsilon, so delta in the Greek alphabet, and then after that comes epsilon in the Greek alphabet, right? So that's why he named it epsilon, because it was on the other side of the QRS complex. Also because epsilon means small, so if you have something it's really hard to see usually, these in V1 and maybe V2, V3, and it should be without right bundle branch block as well. When you have these, then it might be arrhythmogenic cardiomyopathy. I can't remember the RVC it's called, but it's kind of a cardiomyopathy of arrhythmogenic and young people. And you move on to the ST segment, and that's where you have your brugada, which we looked at, where you have a ST elevation with a inversion and going down to an inverted T wave, and maybe that's a type 1, and then you have a type 2 where it's a saddleback. And then you have a long QTC. And we mentioned that above 500 milliseconds, that's where it begins to becomes really dangerous. And you measure it by going to the isoelectric line from the slope like that. And you have the last one, which is a bifascicular block, and that's not really in here. That's more like QRS complex in itself. But if you have a bifascicular block, then that could also be something that may give you syncope and needs to be dealt with. And all of these syndromes are syndromes of usually the young or younger people, and if you catch them, then you can save a life. So that's why we always when I write on the advice of David Carr and Mattu, I write when I have a syncope patient, no signs, no dagger-like, no dagger-like Q waves, no delta wave, no epsilon wave, no Brugada signs, and no prolonged QTC, no signs of bifascicular block. All right, so let's go into these a bit. So here we have an ECG with, which if you just go where the money is, right? So you have very, very low, you have someone who is syncopized and have very deep Q waves in the lateral, in the inferior leads here, and also somewhat in the precordial leads here. And you may even have some of the, this is also hypertrophic, left ventricular hypertrophy, because there might be 1, 2, 3, 4, 5, 6 even here, and then more here, right? So the S wave in V2, sorry, I measured the other one, S wave here, so 1, 2, 3, 4, 5, 6, maybe 7, and here it's, we're already above the 7, so hypertrophia along with Q waves that are deep. This is the definition of hypertrophic cardiomyopathy in the inferior leads and V5, V6, right? Okay, here we have what looks like a Brugada's phenomenon, if I'm not mistaken. It could also be a TCA intoxication. We'll get back to that because that has a dominant R in AVL. In AVR. But it seems like it may be some Brugada phenomenon going on here with maybe a type 2 Brugada with a saddleback kind of configuration here. And so you have two types of Brugadas, right? You have this one where it goes up here, where you have ST elevation, and then it goes down into a biphasic, go into an inverted T wave. And then you have the type 2, where you have this saddleback configuration, and you can make a triangle beneath it to make sure that it's not just lead misplacement. All right. If you do see Brugada, that is not a diagnosis in and of itself. You need to correlate it with clinical signs. So you identify the patterns in V1 and V2. And then you see if it fits with the symptoms, or if it's a what you call a phenocopy. There's different syndromes, such as, I can't remember actually, hyperkalemia, I think, that can make a Brugada-like pattern. And if you think that there's no other causes than a primary Brugada, then you treat it, and usually you have to avoid certain things, such as TCA, I think, for Brugada. But check out the EM cases ECG block on that. You just have to pick it up, right? That's all, pattern recognize it. Then you can always check this for details or ask your cardiologist. Okay, so ignore this. Here you have some really deep T waves in almost all leads here. And really deep T waves, depending on the history, in someone who's just syncopized, without, importantly, it doesn't have T wave inversion here in V1, and B3 has, but not here. But really, they can be even deeper than this. Deep T waves, maybe what we call cerebral T waves. That's something that I haven't mentioned yet, but cerebral T waves is something we see, for instance, in subarachnoid hemorrhage or high ICP. So, and this is just to mention that for all syncopes, you also have to think of the catastrophes. So, and in my neuro video, the 5-hour neuro video, I go through the differences between transient loss of consciousness and permanent loss of consciousness, like strokes. They don't get up. If they are unconscious, they don't get up. Almost like without any exception. But these, they do get up, right? So it might be some PE or subarachnoid hemorrhage or intra-abdominal bleed or shock. And if that's the case, right, a ruptured ectopic or something like that, then they will get up, but they will not be the same. That's why I put this. They're not normal after a syncope. The PEs, they're not the same. Like there was this study a couple of years ago that really made us think that all patients had PE when they're syncopized, but they don't. You have to think of it if the patient is altered in some way. I've had a couple of patients with subarachnoid hemorrhage that had syncope, but they had headache or they were severely throwing up. They had signs of increased ICP. Right. The same vein, if you have a PE and you syncopize, then you will usually have desaturation. You'll have you've just been a cardiac arrest, right? Almost. So you have signs of your PE in some sort of way, either on the ECG or vital signs or so on the history. All right, and the same goes with shock. So these catastrophes you have to remember and rule out, but usually you can do it from the history and how the patient is looking. Okay, so here this is a bit more subtle, but we do have some T wave inversion also here in the precordials and also here actually. And this is a patient who's syncopized, so is more like the Kosuke sign is more to distinguish between ACS and PE, right? So we may have that in our radar, but we do see something else here. We do see this small blip here, and that is what we call an epsilon wave. And here's the rest of the criteria. It only exists 50% of the time in your arrhythmogenic cardiomyopathies, but it's one of those things that we don't want to miss. Also, they usually have, in the absence of RBBB, these T-wave inversions that we talked about. Okay, so that's it. We also have to think of catastrophes. So if someone is transient loss of consciousness and you don't think there's a seizure, or you cannot rule out arrhythmogenic causes, then you'll have to look at the pretest probability, right? Is there a high risk of arrhythmogenic cause from the history? You have to rule out the catastrophes. Do they look different? Are they unstable? Or have the signs of, for instance, intracranial hemorrhage or intracranial problems or interabdominal hemorrhage? Then you look for the obvious things, brady and tachycardia, and then you look for the more subtle things systemically. Okay, that's transient loss of consciousness. Then we'll move on to the last bits here. So toxicology, and this is a lecture in and of its own. It's even a speciality in and of its own, toxicologist. But I'll just give you some of the ECG signs that I think are important. So there's digoxin. It's a great imitator as well. It can present with a lot of things, but I'll give you some of them. And then the others here, beta blockers, calcium channel blockers, and are regular, really wide complex tachycardias, such as TCA and hyperkalemia. Okay, so here we have an ECG in an elderly lady with atrial fibrillation that comes in with having thrown up for a couple of days, and she's a little bit tachycardic, but the main thing here to look at is these sloping kind of down and up ST segments. and kind of like, this is classical for like these Salvador Dali kind of patterns, which is digoxin intoxication. Right? Salvador Dali, but also maybe inverted or biphasic P waves, and shortened QT interval. Then you have here, this is a really wide and frequency around it's maybe 120 only, but I've seen them up to 130, 140 sometimes, but they're not like these VT 100, 200, and 180. They're like usually normal frequency or up to 130, 140, 50, and it's really wide. So there's two things we should think about here. There is TCA intoxication and there is hyperkalemia. And TCA intoxication usually have a really dominant R wave here. So so this probably is TCA intoxication. The more easier way of doing it is just take a potassium. If the potassium is normal, then it's a TCA. It can be something called AVIR, I think it's called, which is a post-STEMI syndrome that is only seen in the cardiologist's department and is self-limiting. You should not treat it. But we'll leave that out of the picture. So here we see that dominant R, and this is the SALT syndrome. The SALT syndrome was named after an article I'll reference soon. Shock or seizure, altered mental status, long QTC, the Allen-2's really regular and really wide complex tachycardia, and then these terminal R waves and AVR. The treatment for this, as an emergency physician, take the arterial blood gas first, see if there's hyperkalemia. If there's not, then just give bicarb. The problem is with the bicarb is that you can maximally give 6 millimoles per kilo, and if they've taken a lot, then that might not be enough to treat them. What you want to see is that you have a narrowing of your QRS at least to below 140. There might be 120 to 104. That depends. Then you don't want to exceed 155 in millimoles of sodium, and you don't want to exceed the normal, like your normal range is like 6 to 8 millimoles of sodium per 24 hours increase, right? So there's an absolute and there's an increase criteria as well. And then your pH, you don't want them to become too metabolically alkalotic. So that's what you're trying to achieve with your sodium bicarbonate. And sometimes you get above these, and then you have to do the second line. And the second line is more complex, and sometimes it'll just go to ECMO for these patients with TCA intoxication. If they do cease, don't give them phenytoin. That'll kill them. Or that will make them worse. You have to give them benzodiazepines, or you can maybe give them Keppra or propofol, right? And the QRS widening is important as a prognostic marker. So if you have someone with an intoxication that you do think is TCA, then it's the width of the QRS complex determines kind of how bad they are. All right. Here are some of the references. All right. Here we have someone who is really going really slow, and there's even AV dissociation, it seems. And that's kind of all I want to say about this. This was a patient who has taken a lot of beta blockers as a suicide attempt, and this is treatment for this. Just remember to give high dose insulin and call your ICU fast, because sometimes they can be dialyzed, sometimes they need ECMO. Check up, and usually the main reason for this not working is not giving enough insulin. You have to give uncomfortably high doses of insulin for these patients. But check out the EM cases link if you want to go through this algorithm it's interesting. If it's calcium channel blockers, you can give them calcium as well. But in general, it's high dose insulin that is the mainstay here, if not ECMO, because you cannot pace them. They will the heart is into hibernation. All right. Okay. Then we have hyperkalemia. Hyperkalemia is you have these peaked T waves, right? That's what the books usually say. But it really depends on how much potassium, how big the concentration is. Above 6.5. Above 6.5, that's where you have your critical risk of ECG changes, and the first change may be VT. So that's why they always should be on telemetry when they're above 6.5. When that is said, 5.5 is kind of a bit, and below is normal, down to the lower reference. And usually you can give them fluids to get them to normal levels, either because the kidney may function better or the concentration changes. But it's important the thing of if they have 5.5 to 6.5 and they have ECG changes, or you think that they are increasing fast, then we should also put them on telemetry and treat them with the calcium gluconate if they develop any of these changes at any time. And the thing is, QRS prolongation is the extreme. That's usually when they have really, really high. But something that we often don't think of is bradycardia. And the Mattu has this small lecture about this. That's really good. And then junctional rhythms, of course. So bradycardia and junctional rhythms is something that is highly related to adverse events in hyperkalemia. So think of that as well. So here's just to show that the guidelines from ERC, and here they show us also the ECG changes, flattening of T waves and peak T waves and bradycardia and so on, QRS prolongation. And then if they do develop any of these changes, then you give them calcium gluconate. The calcium gluconate will work within a couple of minutes. You get 10 milliliters of 10% over 2 to 3 minutes. Here it says 10 minutes, but usually a new Swedish article told us that it's okay to give it over a few minutes. It's different with the calcium chloride, which is 3 times more potent, right? So you only have to give a third of it. Usually give 30 milliliters of it though, but it's 3 times more potent than gluconate. And you usually have to give it centrally because it's more toxic to your vessels. The important thing about calcium gluconate is that it only stabilizes the membrane. It doesn't do anything to the potassium, so you need to treat this in parallel. And you have to repeat it if you haven't treated the potassium to a low level, because it only has a duration of around 20 to 40 minutes. Here's the Swedish article saying kind of the same thing as the ERC article. I just wanted to pick out some pearls here. So the normal level is below 5.5, right? And some chronic kidney disease patients may have adapted to a higher normal level of potassium, but that's in specific cases. Then the treatment of driving out temporarily, driving down your potassium is high dose is insulin and beta blockers, right? And the beta blockers is high dose, is higher dose inhalation than usually is. I think it's like, I can't remember, it's like 10 or 20 instead of it's like a 4-time dose, or you can give it intramuscularly. And this in combination, you may expect to find 0.5 to 1.5 millimoles reduction, and it's only temporarily, right? So while this is happening, you have to give the patient fluids to dilute, and you have to give the patient consider dialysis if that's important. If you remove the potassium in that way, That's a fast reduction as well. Or you have to give them Resonium and treat the underlying problem. So if they have kidney disease, then you have to fix the kidneys, right? Or something like stuff like that, right? So you cannot rely on calcium. You cannot rely on insulin. These are emergency treatments until you can drive the potassium out. We talked about over 6.5. That's telemetry. The way you give glucose insulin, there's different ways of doing it, and all guidelines says something different. But I think I like this way of rule of thumb here in the Swedish article, where you do give 20 units of fast acting insulin in 500 milliliters or 40 in 1 liter of 10% glucose, and you bolus it over 200. Then you bolus 250 milliliters in over 15 minutes, and then give the rest over 1 to 2 hours infusion, and then you take venous blood gases and glucose to control and the rate of this. Okay. All right. Here were this is an EM-Crit oldie but goodie from where I have this table, and this was from this year in Läkartidningen in Sweden. All right, that's toxicology. Moving on to pericarditis, just one slide here. Dr. Smith usually says that you diagnose pericarditis at your peril, and I'm going to have 3 criteria, which are these that may distinguish between STEMI and pericarditis. Concave STs, that's something that mainly exists in STEMI. ST depression is something that also mainly exists in STEMI. And ST elevation in lead 3, more so than lead 2, is also something that only exists in STEMI. But bear in mind, so you need to look for the combination of all these 3. But again, you diagnose pericarditis at your peril. If there are not any other signs of it, like pericardial effusion or a strong history, then consider talking with your cardiologists, especially if this is an older patient. And EM Cases did a deep dive in this. I don't remember if I have the references for this, but EM Cases did a recent deep dive on pericarditis, where you go into all the nuances of pericarditis, so please check that out. All right, last one here, dyspnea. So for dyspnea, in general, you can look at it systematically, but we want to own in on the PE thing. And here's a great overview of the what's what of this very often quite specific but not so sensitive findings in PE with ECG. And if they don't have any of these and they don't have any POCUS findings, then it's probably not a big one. Let's just say that. I'm sure there nothing is absolute, but then it's probably not a big one. Sinus tachycardia is quite common, right? And that's the most common pattern. And then you may see your blocks, the right-sided blocks. You might see right ventricular strain. Again, I said there's overlap between the strain and the hypertrophy. You may see in right axis deviation. You might see a dominant R wave in V1, which you also see in hypertrophy, right? You might see P pulmonale, pulmonal, which is a P wave. You may see the classical but non-sensitive and non-specific finding of S1QT3 with an S wave downwards in 1, and a Q wave a Q wave in 3, and then an inverted T wave. And then there's always, like, is Q wave supposed to be significant or non-significant? Is all right, and how deep should they be? Like it's a very, I guess there's an instrument reliability here as well. Yeah. Then you have, I am not sure about the clockwise rotation. I've never heard about that. Then you have atrial tachydysrhythmia. So any flutter and fibrillation, like, can be an underlying PE. And then you may have your non-specific ST and T changes. These are quite common, and that's why it's hard to distinguish from ACS. But here we have the Kosuke sign, and here's the article for Kosuke. Negative T waves in lead 3 and V1 were observed in only 1% of their patients. I think they have 350 patients, compared with 88 of patients with acute PE. The sensitivity, specificity, and so on is 88% sensitive, so it's not an all, but most. It's very specific if you do find it. So in conclusion, the presence of negative T waves in both lead 3 and V1 allows PU to be differentiated simply but accurately from ACS. So if you have one of these like diffusely inverted T waves, and this is definitely a sign to look out for to say whether to go to the CT or to go to non-STEMI, maybe OMI treatment. Okay. And this is my last slide. I just wanted to show you one more of these Kosuke patterns. And this one, I must say, even looks a bit like a Brugada type pattern. This is one of where my Gestalt would say I had to go to check out whether or not that is true. But it also depends on the history. If it's transient loss of consciousness, then yeah. If it's just dyspnea, then I'll look at the inverted T waves all over here and go from there. It even has, and I think the Brugada one, it's kind of, this looks, when I look at it a second time here, it looks a bit right, right? It looks maybe hemi right, maybe full right. It's almost an RSR, right? So it's probably just a right bundle with negative T waves in both here and here. And let's see what's the axis. The axis is also isoelectric kind of, like, but maybe towards the right on both. Definitely a strange axis, but it's maybe just isoelectric, maybe to the right. Okay, so PE here was the diagnosis at least. All right. Thank you for going through the lecture, and I hope to see you again in the next one. Thank you.